Okay, all right. So, good morning, everyone. My name is Dr. Cecil, Consultant State Quality Assurance Unit. Sigi se, we will be mixing English and Manipuri both. So, basically, any NQAS ki training design to matamda, we do it separately for subcenters and we do separately for other level of facilities like CHC, PHC, and district hospital. So 2 days khaktangi oibanina, we will be mixing it together to have district hospital ki part khara ama, PHC ki part khara ama, then subcenters ki part khara ama. Admain tauraganda design tauzabani. So it is yamna detail mak chatragasu, just the basics that we need to have in NQAS adugi mayamdo just discuss tausena tauzabani. Clinical part kumba adagi moigi SSS ki technical loiba questions natabida facility ki infrastructure magi records magi thambam thokpa adugumba mayamduda oina hena haidi baseline akoina kamaina NQAS se implement taugadagi habado adomda oina onjanjabani ko. So let's begin. So for today, we will be focusing more on the service provision, the inputs, the service provision, the patient rights, the inputs, and the support services. Tomorrow, we will be going on with the clinical services part, the quality management part, the infection control, and the outcome indicators in some of the quick area of concern. Natragasu facility the implement tawgada report khara ama with pictures and all those things. We will cover it tomorrow, but let's focus more on the service provision, the patient rights and inputs, and support services for today. As I can see from the pre-test se da akoigi yam luga da question mayam na yam hadi yam commonly answer tawrakpasu yawe aduga yamna live question yam mayamna yam kanna miss tauba adusu yawe ko. So for example, like I think kanodi, one second, what is the minimum benchmark score for certification under NQAS? This is a very easy question. Mayamna most about 41 responses pangbada 19 responses sigi questions e la lekwa. This is nowhere included in NQAS or anything, but this is akoigi NQAS ama certified tauge hai taragadi 70% phanggadawuniko. National level ki certification tauge hai taragadi we need to score 70%. It is not 80%. 80% phangbagi need oide. It is only 70%. Aduma katang ay clear tok ningi. Atay there are certain questions kitang technical oiba ko na huren training se yaura aba matung do oina khangakadawa mayam ama lanba natraga huziki oina oriented oidabagi yawe. That's okay. But I just want you all to know ki minimum akoigi score NQAS na phangadawa se it is just 70%. So moving on, for akoigi quality program se it is called quality assurance and patient safety, and we have 6 wings on it. First is the national quality assurance standards. Second and third is the kayakalp and eco-friendly. Second is kayakalp and eco-friendly, which is going on right now. Kayakalp deals with the sanitation, hygiene, and infection control of the facility. Lakshya, I think everybody knows it is for CHCs and district hospital, which takes care of the labor room and maternity OT. NQAS ka chap manai, but the departments that we assess in Lakshya is maternity OT and labor room. Muskan Haragana, it is about child-friendly services for pediatric population up to 12 years of age ki, pediatric OPD, pediatric ward, NRC, SNCU, NBSU, sugumba mayamda NQAS tauboduniko. The everything is same with NQAS measurement system ki NQAS ki measurement system siga Lakshya, Muskan, all these are similar. Only thing is Lakshya the labor room and maternity OT khaktang the yengi incentive amount chawe. Muskandana pediatric OPD, pediatric ward, NRC, nutritional rehabilitation center, NBSU, adagi SNCU adudaiduda akoina assess tawbani. Then Mera Aspatal is not very much functional as of now. It is same as patient satisfaction survey. ꯑꯩꯈꯣꯏꯅ patient satisfaction survey se hospital na lobagi mahutta patient ki phone do da mera hospital haiba app se adum hap khraga mana facility ma changbada magi feedback se direct ministry ki level da yaunana ba feedback piba portal amani mera hospital se, which will be implemented in the near future. Then Sakushal is Huzik Phogi Oina Sakushal is about assessment of patient safety, like patient safety in the hospital, mostly district hospitals. Huzik Phogda Taurise Sakushal is about district patient safety in district hospital ki level da. So these are the wings of quality assurance and patient safety. Now we will be focusing more on the national quality assurance standards. We are focusing today on mainly district hospitals, PHCs, and PHCs, CHCs, and sub centers. अखोई government of India की ministry की order की मखादा, I think everybody must be knowing, by 2025 की December भोक्ता all the health 50% of all health facilities are to certify for NQAS. It can be state certification OBI, it can be national certification OBI. If any facility, if they cannot get national certification, if they are certified for the certified at state level, it is equally good as national certification. Taupatabu magi incentive amount laite haibagi wani. Otherwise, when a state certified tautaragadi, state quality assurance unit will be providing them funds to traverse the gap so that they can apply for national certification. So basically, India ki 50% of the health facilities NQA certified tauba means state khudingmaki 50% of the facilities NQA certified tauba, including state certification as well as national certification. State khudingmaki 50% public health facilities NQA certified tauba hai taragadi, at the district level, we need to certify 50% of all health facilities under the jurisdiction of that district as NQA certified, may it be state certification or may it be national certification. One good point about primary level health facility is that for primary health centers and sub centers, their assessment will be done at the district level itself. The district assessors will be assessing the facilities. They will send the scores to the state. The state will verify it. The state will not physically visit the sub centers or the primary health centers. If the district assessment report is sent through CMO, the state will take it as verified, and that particular facility, primary level health facility, will be declared as state certified facility. Aduna yam like or state certified otherwise, and we have instructions from the ministry to certify, at least to have state certification of 50% of all the facilities in the district, in the state, by 2025 December. So this is the ministry order that says NQAS certification of 50% of health facilities by December 2025 and 100% of all facilities by December 2026. So I request all the district units, mostly Huzik Valley Dagidi, there are many certifications coming up, both state as well as national. But I request from your district to apply for state certification as well as national certification, because without the facilities from your district, it is not possible for us to certify 50% of the facilities in our state. Aduga huziki aina haiba pointo, we need we just need the certification from the district level for primary level of healthcare facilities like sub centers, like UPHCs, like primary health centers. District ki level dagi assessment tawraga akoida moise state certified tawba yare haina tharak taragadi, that is considered as final. Aduga we will be providing releasing funds for traversing gaps for those facilities. That way they can work more for national certification for NQAS. So to have NQAS implemented at the facility level, there are certain steps that we need to do. First is the organizational framework. Organizational framework in the district hospital or in the PHC, CHC or sub centers. First thing what we need to do is have a quality team for the whole facility. District hospital ki quality team ama laiba, then department khudingmak ki quality circle amamam laiba. Why we are doing this is because quality assurance NQAS implement tauge haitaragadi a single person cannot do everything. Records ki part, infrastructure ki part, aesthetics ki part, record reviews ki part, the training ki part. Sigi mayam say it needs a lot of manpower to train the staffs. Aduna mi khara khomjalaga, not many, but at least 5-6 people khomjalakanda quality team sembiba for the whole facility and quality circle for each department, like quality circle for OPD, quality circle for IPD, quality circle for laboratory, quality circle for labor room, quality circle for pediatric OPD, like that, and quality team for Churchandpur District Hospital, quality team for District Hospital Senapati, Sumaina. So that is the organizational framework. We need to have a strong team first, quality team ama laiba, then adugi makhada quality circle department loiba mayam ama laiba. Aduga adu form tawraba matungda we need to adapt ourselves. We need to we need to be aware of the measurement system of NQAS. Measurement system haitaragadi, it is basically the checklist. How do we give marks in the checklist? How do we implement the checklist? Until and unless we can measure something, we cannot improve it. Akoina sigi pot say, for example, we our uh, uh, bed occupancy rate has a, if we don't know how many patients are being admitted in the ward, we will not be able to improve it. Labor room da angang macha kaya poke haibagi hauzik ki akhoi measurement se laitragadi, we will not be able to improve it. So we need to first know where we stand. So measurement system is very important, because without a measurement system, if we don't know, if we don't measure it, we will not be able to improve it. Then training and capacity building at the departmental or facility levels. ꯑꯩꯈꯣꯏꯅ NQAS implement ꯇꯧꯕ ꯃꯇꯝꯗ ꯀꯔꯤ ꯀꯔꯤꯗ focus ꯇꯧꯗꯣꯏꯅꯣ. We do not need ꯌꯥꯝꯅ vast ꯑꯣꯏꯕ ꯑꯩꯈꯣꯏꯒꯤ ꯄꯩꯁꯥ ꯌꯥꯝ ꯆꯪꯕ ꯑꯗꯒꯤ different other directions ꯗ focus ꯇꯧꯕꯒꯤ need ꯑꯣꯏꯗꯦ. We will be focusing just on the checklist. Whatever is written on the checklist, we will just literally follow it. If the checklist says you need to have these 10 items in your ward, then we will focus only on those 10 items, nothing more, nothing less. So when it's an open book examination, open book to the hirami baput mayamdo, we just have to implement it in our facility, nothing more, nothing less. Then after we implement this NQAS, there will be assessments. Assessment of matamda, there will be certain gaps. Those certain gaps will be analyzed, and accordingly when quality management tool tawrako matamda horen khanga ani, gaps will be analyzed, and then gaps 70% yaunanaba pukhalakadoiba. If you are scoring more than 75 or 80, just try for state or national certification and it's done. Kaigumba, if your score is about 50 or 60%, where are we getting 0 marks? Where are we getting NQAS ki di 2 marks, and every checkpoint the 2 marks and highest ni. So if we are getting 2 marks on that, we will try to sustain it. If we are getting 0 marks, then we will try to prioritize anything which can be done very easily. 0 phangbudo 1 da onthoknaba, 2 1 phangbudo 2 da onthoknaba. That is called gap analysis. Then facility level activities, that's then certification amalani. Certification can be state certification, one, and second is national certification that comes with a huge incentive. So let's see, this is the organizational framework that I was talking about. At facility level, there is this quality, at the facility level, there is this quality team. Quality team hai taragadi, it is facility level the oidoni. Okay, so quality team hai taragadi facility level oidoini aduga quality circle hai taragadi departmental oidoine bako. So facility gi lim na for facility gi teams na bagi facility da they will work on implementation of NQAS. District level will support the facility in assessment and other funds and everything. Moi ki district level ga facility ki level sina pukhalak pado state level da we will see and state certified tauthoni state certified tauthoba matungda, let's say within 3 to 6 months ki manungda we will try for national applications, and national applications tuna ngasai gi national level gi certification gi unit tuna pirakadoine bako. Then so assessment process, let's just once look at the assessment process. Everybody must be aware of it, but just let's have a refresh. First is the internal assessment, which is done by the facility itself. Facility do not checklist puthuokanda mayam on the table. They to have an internal assessment, it doesn't need any work, okay, physical work mapanda thoktana chatpagi need oideko. We just have to sit down all the department ki heads mayam ama in charge mayam ama table amada phammaga 1 day sida isa isa ki department ta laiba laitaba mayam do adugido assessment tawuduni, that is called internal assessment. Internal assessment sida is the kaigumba, if it is less than 70%, then we will work on it more. Okay, 70% se phangnanaba where ki when ki where can we improve our score haibado okay internal assessment ta khangdoini. Then after when we cross 70% helakpa matung dadi we will call for district assessment. District assessment tawba matamda if more than 70% henta ragadi they will apply for state assessment. If kaigumba PHC oiraba natragana arm subcenter oiraba, then this state assessment say not necessary. District assessment tagi direct national assessment sida chatkadoini ko. State assessment tawroi for PHCs and arm subcenters. So district assessment se tawraga if more than 70% phangta ragadi they will have state certification. So internal assessment ta less than 70% phangadi 70% phangnanaba tawbiro. If more than 70% phangta ragadi district assessment ma tawhanbiro. District assessment to the if less than 70% oita ragadi, please try to improve along with the district team. Please try to analyze the gaps and try to find out where can we score more, and please target the low hanging fruits only. Please do not try to spend a huge amount on gap closure, because there are many checkpoints. Say, on those checkpoints, please try to see which are the ones which will be more affordable and will give you more marks. So, for example, I always used to say to have a boundary wall around a facility is equally as good as a doctor's good handwriting. Doctor na handwriting phajana irambadusu mark ani phangi, aduga facility gi mapanda boundary wall khabadusu mark ani phangi. So we can decide on which areas we can close the gaps easily. So district assessment tawraba matungda for CHCs and district hospitals. For CHCs and district hospitals, state assessment will be done. State assessment tawraba matungda we will go for national assessment if it is more than 70%. Aduga sigi district assessment se district quality assurance unit na every quarterly tawbiyo hai ko. Quarterly tawbiyo hai se huziki oina di akhoida matam laitabanina, we request the facility to have the internal assessment, bring up the score to more than 70%. Please consult with the district team to have the district level assessment. If it is more than 70% for primary level facilities, we will go for national certification. We will certify at the state level. For district hospitals and CHCs, one state assessment will be conducted and state certification will be given. After that, in 3 to 6 months, when the facility is ready, we will go for national assessment. Then this is the process which I was talking about here. As we can see, this is directly from the NHSRC slide, and they have clearly mentioned that District Quality Assurance Committee is authorized to conduct state level assessments which are validated by State Quality Assurance Committee. We at State Quality Assurance Unit will not challenge your assessments. We will take it if it is forwarded by the CMO. we will accept it, we will verify it, and then we will straight away go for state certification. There are certain advantages of state certification, like giving not much, but still financial support to the facilities for traversing the gaps also. So when a district level assessment ama quality assurance district quality assurance unit na taurani, then adugi poto that will be sent to state quality assurance unit. State level assessments will be conducted for only secondary level facilities, primary level facilities ki tauraroi. Then state certification will be given. After that, in due course of time, like 3 to 6 months, national certification we will apply, and then if nationally certified oitaragadi, they will get incentivization. So let's go to NQAS. How do we measure? How do we measure a facility? So measurement system of NQAS HICO. So NQAS, for any facility may it be district hospital or CHC or PHC or subcenters, UPHCs, we see them in broad 8 areas of concern. Broad 8 areas of concern. Sige manungda, there will be many measurable elements, there will be many checkpoints, there will be many means of verification, but broadly we will assess a facility, a department in broad 8 areas of concerns. IPD su 8 areas of concern the yengi, OPD su 8 areas of concern the yengi, subcenter as a whole 8 areas of concern the yengi. So what are these 8 areas of concern? The first one is the service provision. Service provision is about the availability of services. As per IPHS norms, what services are supposed to be provided by OPD of that particular district hospital, that is called service provision. Haibadi magi keno emergency services labra, ANC tobra, RMNCHA ki services labra, lab labra, diagnostics ki services labra, drugs ki services labra, all those things covered under service provision. Patient rights is when all those services which are being provided in service provision, those services are being provided for the convenience of the patients. Accessibility, affordability, ko affordable ohenba, accessible ohenba, those are patient rights. Just like for ramps on the stairs, railings on the stairs for disabled patient, male and female toilets, disabled friendly toilets. Sugumba mayam say it all comes under patient ki rights. IC materials, different IC materials, directional signage, facility ki layout, all those things comes under patient rights. Inputs is all about your facility infrastructure, HR, manpower, drugs, diagnostics, which are like consumables. Okay, port oina labra haibado. Port oina labra, doctor labra, nurse labra, doctor do train taurabra, nurse do train taurabra, CHO train taurabra. Then do you have a separate examination room, adequate space in the labor room, adequate beds, patient amenities, stethoscope, BP instruments, measuring tape, footstool, all those things will come in inputs. Then comes number 4, that is the support services. Support services, it is the non-clinical management. Non-clinical management, first is your kayakal ki type ta facility gi akoigi magi cleanliness kumba akoigi landscaping gumba adugumba mayamam laani. Second is about your management of drugs and diagnostics. How much stocks are you pharmacy gi manungda, how much stocks are being managed, buffer stock na kya no, reorder levels na kya no, all those things will come. Support services, the laundry services kamaina handle tawe, linen kamaina handle tawe, adagi all non-clinical oiba RKS ki paisa kamaina handle tawe, contractual basis ta koina staff hire tautaragadi adu kamaina manage tawe, all those things comes under support services. Number 5, the clinical services. Hi, clinical services is divided into 3 parts. The first part is about just general OPD gi registration kamai ta holi ana ba yeng ba matam da kadai da hana changi OPD gi keno se magi doctor na prescription iba matam da singai yeng ba nurse na hida kapa matam da what are the things that a nurse sees when before administering an injection. All those things are it comes under first part of clinical services. Second is about technical knowledge about handling cases like uh, pediatric ki haitaragadi magi emergency triage treatment protocol kamain tawi CPR kamain p adugumba all those things or kaigumba patient ama dehydration laktaragadi masi kamain handle tawi is it as per the standard treatment guidelines or what kind of guidelines do we follow prescription iba matamda magi iramiba hidak mayamdo the as per the standard treatment guidelines oiba adugumba mayam ama oi and then the last part is specific oiba the specific oiba as per the programs magi specific kano oibado adu oibra oidabrana clinical services the yengi. Then infection control. Infection control is, as we all know, as kayakal mayamsu huzik huzik tauribanina, as we all know, it is about biomedical waste and infection control. Infection control haina infection control khatangi nate. It is about biomedical waste management as well as infection control. There are brain infection control ki lakpada it deals with hand hygiene, personal protective equipments, instruments, sterilization, it deals with environmental sterilization, all those things. Then quality management ki part. Quality management deals with akoigi facility ki manungda any kind of gap ama lairaba natragana any kind of akoigi satisfactions akoina kanodagi feedback se lawgadawba oiraba it all comes under quality management. Quality management ta ngasai facility gi quality team labor quality circle labor ka haise it all comes under quality management. Facility amada magi whole functioning se OPD amada anaba malaaga karai da hana chatkani labor room da anga miron bi amana emergency da laaga karai da pushangani pharmacy da dispensing counter da na kai thamdoino kamai thamdoino everything will be written in the standard operating procedure of that particular department which is included in the quality management part of this NQAS. Quality management part sida yam chawna standard operating procedure gi checkpoint ama yawi aduga arm sub centers ki di there is no standard operating procedure they call it work instructions high sub center ki level dana aduga standard operating procedure high for the level of this PHC, CHCs and district hospitals. All those will come under quality management. Patient satisfaction will come under quality management. Quality team and quality circle, PDCA cycle, quality tools, hemba adugumba mayam the loina quality management the lactoni. And last is your outcome indicator, and this can be considered as your report card. For a facility, for a labor room amada angang kaya handak thada pokre nungdangda how many deliveries were conducted at the night, how many last trimester pregnancies akoigi labor room sida poi, how many referrals was done, PPH cam thoki adugumba all data facts and figures, all those things calculations will come under outcome indicators. Outcome indicator is very scoring, it is all calculations which is done supposed to be done on a table. Departmental heads in charge, sister in charge mayam pulla kanda hotmin nagadaw ngakani sige sisu for now what kadobadi pangna yaude. If you have the data we will provide you the Excel sheet and everything will be auto calculated. We just need the data ki how many deliveries were conducted, how many deliveries were conducted at night, and according to those immunization kyam tawgiba follow up kyam tawgiba adugumba mayamse everything will be auto calculated. You just need the data from your OPD records or your inpatient records. Aduna outcome indicator will be for every department khudingmakki. Please remember every department will have outcome indicator for lab, outcome indicator for labor room, outcome indicator for IPD, but there is one more thing called as key performance indicator. Key performance indicator is a facility level data that will be called as key performance indicator for district hospital Churchandpur. key performance indicator for district hospital Senapati, key performance indicator for Pearson, like that. An outcome indicator is a departmental level record for OPD, IPD, lab, or hemodialysis, or whatever. Department ki oidoni asagi outcome indicator haisena. Key performance indicator will be for the whole facility. Cool. So let's just break it down. Area of concern sigi mantunga. In the after the 8 broad areas of concerns, we will have standards. We will have many standards. Standard kudingmaki manungda, we will have measurable element, and at the end, last, we will have checkpoints. So the quite broad oibaduna area of concern, then comes the standards, then comes the measurable elements, and then comes the checkpoint. Area of concern, standard, measurable element, and checkpoint. ASMC. ASMC. So, ngasaygi area of concern dudi aina ngasay hijackre. This is a broad area of concern. Standards to na area of concern dugi kitang amuk breakdown tarakpa, but still broad oiriko. When it comes to measurable elements sidadi kitang magi specific oiba hela ani, and then in the checkpoints it will be very specific. They will ask you like by the specific oiba point to hangani, as we can see in the checklist. We will see further. So area of concern, there will be many standards. In one standard, there will be many measurable elements. In one measurable element, there will be many checkpoints. And then sigi checkpoint, sigi matung inna the departmental or hospital scorecard to generate tawakadoini. I'll repeat this again. Area of concern amamamda, there will be many standards. Standards amamam gi manungda, there will be many measurable elements. Measurable element mayamgi manungda, there will be many checkpoints. And then as per how much do we score in each checkpoint, say, ECG accordingly, we will have the hospital scorecard. So this is the model checklist. Just give me 1 minute, please. Hello. Yeah. Sorry. So this is the checklist. So this is the department. This is the area of concern A, which is the service provision. Then this is the measurable element. This is the checkpoint, and this is the means of verification. See, means of verification, as we all know, in from here, like these are all very specifically given what needs to be there in this department. These are the means of verification. These are the ones that we need to target. We need to have at least 50% of all these services provided in this particular department. So service provision, say, I will not go much details. We will just is my slide visible? Can you tell me?
Yes, yes.
Okay. All right. So let's say this is the service provision. Service provision is about, as I have said earlier, magi availability of functional services, availability of functional services. Let's say OPD, the what all OPD is supposed to be there in the district hospital. Labor room dana magi miron bigi ANC tauba, miron bigi magi night delivery tauba, functional services which are supposed to be provided by that particular department, we will deal with in the service provision. We have district hospital that there are six uh, standards. CHC there's six standards, PHC the four standards, UPHC the five standards, and subcenter the two standards. This say for an implementation tawbagi these standards say akoina yam kanna by heart tawdrasu yai ko. This is for the SSR level gini. But just please understand ki service provision, the what we have to do is first, before we do anything, first we have to make sure one service, if it is asked in the service provision, adugi service to provide tohanba machangeba. Otherwise, sida service provided oi haraga ada pot lairami haiba yaroibako. Because let's say, for example, if we declare that we do not provide NCD OPD in service provision, and if we are saying we have glimepiride, metformin, and medicine specialist, that doesn't work like that. So first thing, service provision the yauriba mayamse, it can be very OPD gi room do chawbo orambe ai pikpo orambe ai. It can just be a table, or it can be just a very infrastructure yamna paisa changda bi the same setup ama oirasu kashu kaide. But in a checklist, if they are asking for a service provision in area of concern A, please try to keep it. Adugi poto service provision the kwen lay hai gitaragadi, we can score in inputs or support services wherever applicable oiba matamda. Please don't akuna akoigi hospital sida karam service laigadobano habado. That will be, we can see that from service provision gi checklist to adudagi ubo phangneba. Ada akoina akoigi PHC sidi emergency service pd haitaragadi adudi yararoibako, because in the service provision itself for PHCs it is asked ki emergency services are being provided or not. PHC ki the, they do not ask if doctor is available 24/7 or not in service provision. They are asking in the PHC, is your emergency department functional for 24/7? They are not asking for doctor. It can be a lady health visitor, it can be anybody else, it can be a dresser who is sitting in the emergency minor OT. They are not asking for doctors. So please think it that way. Please think it in a very literal way. What are they asking? If they are asking for an emergency OPD, emergency room where dressing and all those injuries can be managed 24/7, then we can just say yes, we have an emergency room which is open 24/7. They are not asking for doctor is available or not. Doctor available oibra oidabra, that will come in part C. They are just asking for service. If anybody comes to have their problem checked, available oibra oidabra habdo service provision the lapaneba. That's just an example. Then let's go to patient rights. Patient rights is all about accessibility, acceptability, and affordability. Patient rights the we see about patient rights though we see about gender sensitivity, like male female toilets, male female registration counter, all those things. Information signage, IEC materials say when waiting area gi IEC material is different from the area OPD area or any procedural area gi IEC siga khetnai ko. We in the waiting area all sorts of informative IECs like prevention and health promotion, awareness, all those things IEC will be kept in the waiting hall. We will not be pasting any kind of clinical oiba protocol oiba how to okay, manage diabetes, how to manage hypertension. All those IEC materials we will not put in the waiting area. Waiting area like how to prevent this, how to what is a balanced diet, all those things akoina miron bi amana paba matamda immunization gi oiragasu non clinical oiba health promotion or awareness ki activities mayam do adugi potto oina akoina IC material thet kadoini IC material thet pa matamda people usually say that it should be in same color and same size, all those things. It is not about IEC material. It is about directional signage and facility signage. Signage and IEC materials are different. IEC materials will be provided mostly from the National Health Mission. Will have different colors. Don't worry about it. Signage like labor rooms from the chatlagalai, labor room number 1, room number 5, labor room number 6, OPD, room number 7, immunization, room number 8, NBSU. All those things will be in a same color, like blue background with a white text, something like that. It should be similar. Room ki signage, directional signage, all those things needs to be in the same color. But IEC materials need not be in the same color. But please make sure waiting area ki signage, procedural area की signage, OPD की IEC, waiting area की IEC, procedural area की IEC, all needs to be different because अखोइना relevant ओइबा जगहदा थेपियो हाइबनेबा. I can see in waiting areas the 5S key poster mayam thepa. What will patient do with that 5S key IEC in the waiting area? So that needs to be corrected. 5S key IEC needs to be pasted in the like workplace, like OPD oigera, sister ki station oigera. It's not needed in waiting area or any other patient ki ngaibham jaga the need oide dana ko patient ki ngaibham jaga dana relevant oiba IEC prevention or health promotion, all those things. Then informed decision making, it is about consent. Consent say it is very, very important. There is a separate checkpoint. How do we take consent? Bilingual ohenba, paper already defined tauraba, paper should be as per guidelines, witness should be there. The hospital name should be clearly written. Witness, the gimagi patient to give thumb impression, date, time, everything, all about consent. It is there in patient rights. Then privacy and dignity. Privacy and dignity is about if a male doctor is examining a female patient, then a female staff should always be present. Kind of. Then screens or separators all should be available while examination while examining a patient. The female gi tonganba OPD laitaragadi adugi potuma thambiba if vulnerable populations like HIV or any other STD ki patient lagtaragadi or adolescent ki bu oitaragasu mugi separate when thambiba. All those things comes under privacy and dignity. Cashless services and entitlements in patient rights. One of the most important thing that an assessor see is financial incentives. Entitlements are displayed, implemented, and the services are being given to the beneficiaries. For example, JSYG services, is it displayed first of all? Secondly, is it being implemented? Are GSSK services being provided? Are CMHT services being provided? Are PMJAY services being provided? All those financial entitlements are being displayed or not. Family planning gi vasectomy tauba matamda, tubectomy tauba matamda, there are certain incentives for tubectomy. If done, there is incentives that can be that a beneficiary should get. If anything goes wrong, compensation are also there by the government. So all those needs to be displayed, cashless services and entitlements. We need to make sure that any of the essential drug list and essential diagnostic key list, the yauriba tests and drugs are supposed to be provided free of cost. And in that facility, in that particular department, like pharmacy or lab, it should be displayed key all services are free of cost. There are certain financial entitlements being given. First of all, JSY, JSSK, CMHT, PMJAY, family planning, vasectomy and tubectomy, all these needs to be displayed in the waiting area or the waiting hall. Then ethical concerns and its resolutions is mostly about district hospital. Ethical concerns, there is a short checklist. It's little bit complicated, but can be done. Ethical concerns and its resolution. but mostly PHC subcenter ki level da please we have to make sure magi patient ki right se da barrier kano ohenba ko barrier amata lehenda ba disable friendly ohenba toilets disable ohenba how to make disable friendly toilet we just have to put some steel bars ko steel bar gumba khara hapa kanda akoina horen mise changa kanda bar do da paira kanda akoina they can just stand up they can have their toilet changbudo masa mathanda independently changbang ngamdanam ko we it is mandatory to have this ramps mandatory to have railings for disabled people citizenship charter is mandatory citizenship charter hai taragadi it comes under information ko it comes under information citizenship charter is about patient key rights and responsibilities adu the yarakani grievance redressal mechanism adu the yarakani the citizenship charter will make the public understand how many doctors are there, how many multi-purpose workers are there, what are the financial entitlements being given. Adugi mayamda, it all comes under information. We will be talking about this in details later on. Then inputs, as we have said earlier, apna input say infrastructure ki whether the labor room has adequate space, whether the pharmacy has adequate space, infrastructure magi bed thaba matamda bed amaga gi lapna badu phangbra adequate and competent HR adequate and competent HR how many doctors are the doctors trained on CMONC or BMONC or whatever if there is a sister if competency assessment is being done or not haibidi sister ama se BP lobada phajana magi BP loba or any management ama tauba matamda all the sisters all the staffs they must be doing from before but as per guidelines there are certain steps for example BP on ba hai taragasu there are let's say 12 steps that needs to follow while taking a BP for example we will tell the patient not to crisscross their legs hands to be kept on the table at the level of the heart back should be lied down on the chair no talking while taking a BP no tobacco consumption for 30 minutes while taking a BP no caffeine for 2 hours while taking a BP example sugumba mayam se hana loimbak akoina BP loba matamda sisters in a haidi care lobra are these steps being taken care of all those things comes under competence assessment of any staff so that needs to be done aduna competent oiba BP lobadang oitaragasu as simple as taking a BP it is a complicated step if we look from the NQAS point of view physical fire and disaster preparedness fire safety gi sorry fire safety ki we need to have firefighting equipments we need to be trained in the firefighting equipments physical like akoina magi pochai thamba matamda the all the cupboards and everything should be tightened at the back so that if any comes of in times of disaster or in times of earthquake fall tawdana ko drugs and consumables drugs as per the essential drug list should I can drugs assessment for district hospitals, UPHCs, PHCs, it will be as per the EDL. However, for sub-centers, drug assessments will be done as per NQAS checklist. An assessor will not ask any sub-center, do you have the drugs which is there in your essential drug list? Rather, they will go to the checklist and see what all drugs needs to be put as per NQAS. Drugs define tawraga laye ko kanodadi sub-center gidi but district hospital gi magi kanogi di essential drug list mayam se librani yengakani ko and then instruments and equipments for example do we have oxygen cylinders do we have uh, ventus machines do we have suction machines do we have BP or pulse oximeter or whatever instruments and equipments that needs to be there in the facility adugi mayam do libra habito inputs sa yengdoni and then training and performance comes under inputs doctor ki training in-house training oibe hai natragana district level or state level ki training oibe hai all training or training improves the competency of the staffs competency is under this inputs. Then comes support services. I know equipment maintenance. Equipment maintenance, it is about calibration and annual maintenance contract of all the instruments which is there in the for the state of Manipur. We are lucky that the BMMP is rolled out and all the instruments in the district hospital or all the instruments in the CHC up to the level of PHCs, everything is covered in the biomedical equipment maintenance. So there is a specific order. If you haven't seen it, I will share it. There is a specific toll-free number. If you need your facility to have the calibration of all the equipment, you can just dial them. They will come and have their tags on all the instruments that you have. Primary health centers, both the all the equipments and instruments they cover under AMC and calibration. Drugstore and inventory management. Drugstore and inventory management is about buffer stock, then reorder level, minimum order level, all those things. Details the corner laksiko. Then safe, secure, and comfortable environment. Sugum basidaniko kasaigi akoigi boundary wall labra kotpra na haibadoba. Then facility ki upkeep se apna kaya kalta toba dumaina makamapan gi landscaping gumba adugumba mayamdo yengba drains covered oiba oidaba facility ki upkeep broken walls kumba koigi chipped walls kumba adugumba mayamdo the deal tawdone facility upkeep se. Then linen, food, water, electricity. This depends on which level of facility the oidoino habiduma sidala any electricity if solar powered oitaragadi unlimited uninterrupted ne highway are food and water akoigi patient kona food ki services piba, dietary services piba. I would just add one thing here. Most of the health facilities in the state of Manipur, they don't provide food to the patients because of lack of funds, that we understand. But NQAS ki oinadi, food is supposed to be provided to the patients. So what we can do is, for maternity, through JSSK, we are supposed to provide at least diet for the pregnant woman. Aduna NQAS assess matamda, if they ask for dietary services, please say yes. Aduga, please try to provide at least for the pregnant mothers. That will be counted. Not for the whole IPD, but then please try to provide diet for pregnant women. Normal delivery oitaragana for 3 days. CS oitaragana 7 days. If that is provided, you will get a huge mark in your NQAS assessment. Please remember, 3 days for normal delivery, 7 days for CS, diet, just for pregnant women who came for delivery. Rest IPD, no need to provide diet. Diet provide tautaragadi best. If not, ngamdragadi pregnant women khatangi PB over, because diet P you lose a lot of marks. So financial and legal and contractual compliances, as I have said earlier, when outsourced over service that will come under here. Outreach activities, teleconsultation, health days, all these non-clinical ones, all will come under support services. RKS, JAS, patient support groups, all those things will come under support services, which are non-clinical ones. National health programs, management of ASHAs, these are all non-clinical ones which will come under area of concern D, that is support services. Now let's come to the clinical services. As I have said earlier, one is the general, which deals with the registration of the patient, discharge of the patient, LAMA patients, all those things. Specific is about the specific clinical conditions, specific clinical conditions like management of diarrhea, management of snake bite, management of dog bite, management of any other injuries or postpartum hemorrhage. All those things will come under specifics. RMNCHA, the gila ani, Miron B gila ani, all clinical ones. Then comes patient and medication safety, like we will deal with 6 hours of medication safety. We will deal with moments of medication administration. All those things will come under medication, patient and medication safety. Then nursing care na magi patient to inpatient the labor matamda, how do they magi normal continuation sheet may maintain toba, input output chart maintain toba, all those things will come under nursing care. Then the last one is NHP and hemodialysis. Hemodialysis have a separate unit, and NHP is national health programs like National Tuberculosis Elimination Program, National Leprosy Eradication Program, National Program for NCD, IDSP, many other things like RMNCHA, RBSK, all those things will come under national health programs. We will be assessing under area of concern E, that is clinical services. Infection control, as we know, infection control program. Infection control program, we will need to have an infection control team first. For a district hospital, MS tuna lead tauraganda, if you have a microbiologist ama yauhan biro, sister in charge yauhan biro, for a district hospital level, please identify one infection control nurse, ICN. Infection control nurse will be in charge of all this biomedical waste ki monitoring tauba, infection control ki monitoring tauba, then needle prick injury, spill management ki training, all those things. Infection control nurse ama identify tawbiyo aduga infection control nurse tuna overall mana monitoring se loin tawdoneba, because medical superintendent na aduda matam kaithopon ngamoy, microbiologist ki any technical oiba ngasai gi moigi facility labor room gi microbiological surveillance torapagumba adugumba mayamda microbiologist ki koina comment lawni. But as a whole, for the facility, main monitoring the was a infection control nurse ama identify the view, then she can monitor where koina biomedical waste karai jaga da shoy, infection control karai da shoy, instrument sterilization kadai da shoy, instrument processing, environmental disinfection ko sugum bamayam se yenjannaba. Please identify one infection control nurse. So infection control program, the infection control team amaga infection control nurse amakanda amathambama changi. Hand hygiene haitagadi, as we all know, hand hygiene, we follow 6 steps of hand hygiene, which in Hindi we call it as suman ke. Suman ke. There are many hand hygiene instructions implemented, provided from WHO, NHSRC, many. But we in NQAS, SSR mayamna yengbase, we just see suman ke. These are the 6 steps of hand washing, which I will elaborate in while we do infection control. Personal protection, as we all know, personal protection is not only the whole kit, as simple as masks ama uppa, gloves ama uppa, boots tongba, adugumba mayamsu, goggles ama uppa. Those are all personal protection. Personal protection se karamba level da karamba utka dawbano haibadune sida deal tawdoise, and at the same time akoina personal protective equipment ki supply se akoida kayam laige haibado adugi potune sida yengdoise ko. Environmental control like 3 bucket system, 2 bucket system, why taiba matam da disinfection karamba season aba 0.1% solution na karam kan season aba 1% hypochlorite na karam kan season aba 0.5. When do we use 0.5? How do we use 0.5? How do we prepare hypochlorite solution? All comes under this hypochlorite solution. And then comes the biomedical waste management, that's red, yellow, blue puncture proof, white puncture proof, general waste, black, blue, green, all those things will come under biomedical waste management. Then quality management, the detailed hierarchy. Just know that we need a quality team at first before we implement NQAS in our facility. The first thing that we have to do is make a quality team for the whole facility and make quality circles for different departments. We will see patient satisfaction survey. We will do patient satisfaction survey, and then we will analyze with monthly patient kunsa 30 patients patient satisfaction survey gi moida chi se pira kanda moina Likert scale da rating pihalani. As per that rating, we will choose 30 patients, and then we will analyze where are our least scoring attributes. Khwaidagi hen akhoida sonba attributes se kadai da no do yengdoni. patient satisfaction survey. And ESS, it is for primary health centers, community health centers, and district hospitals. Employees also need to give feedback. Employee satisfaction survey. All those, all these formats, please don't worry about any format. We all have the format framed. In case noina hek pamba matamda, we can provide you the patient satisfaction form, we can provide you the employee satisfaction form, the feedback form, complaint form, whatever form, whatever policies, we are here. We have framed everything, so no need to worry about or any noina frame tawgadaba amata nate. You just have to ask koi tharakani, then you just have to implement it in your facility. Then SOPs, one of the most ꯈ꯭ꯋꯥꯏꯗꯒꯤ ꯆꯥꯎꯕ ꯄꯣꯠ quality management ꯇ SOP ꯁꯨ you don't need to worry. We have SOP, general SOP for district hospital, CHCs, PHCs, all SOPs are there. Only thing is you just have to customize it as per your facilities workflow. Because for example, district hospital Thoubal da chatnariba akoigi process of work se district hospital Chuchampur da chatnaramdaba yaibako. So a baseline NQAS ka related oiba SOP madi, we have it, we will share it with you. But then you cannot just copy it, because when an assessor asks how is your process of this thing harakpa matamda noina hai duga SOP duga manada taragadi, they will know that this SOP is not framed in your facility. If it is framed in your facility, hanadi frame tawga laibo itaragadi, then it's very good. Otherwise, if you need SOPs for primary health centers, for labor room, or for there's accident and emergency, or OPD, IPD, wherever, SOP darkar laitaragadi, we have it framed. We can share it with you. You just have to implement it, customize it, and then sign by the respective facility in charges, and that can be kept and implemented. Then process mapping and improvement. This is also for PHC, CHC, and district hospital, not for sub-centers. Sub-centers, the process mapping yang kan taude. Process mapping is, as we all know, brain quality management lake, but just a brief idea. Process mapping is when a patient comes to the facility, they cut a ticket at the OPD registration counter. OPD registration counter, the ticket ka aba matungda, they come to the doctor's chamber, they come to the vitals corner, they get their vitals checked. After checking their vitals, they go to the doctor's waiting, doctor ki consultation room ki waiting area du ngak phamme. Consultation area du ki phamma kanda doctor mu consult tawre. Consult tawra matungda moi lab ta chatle sample piramme blood test ki. Then they go to pharmacy to get the drugs. So this is a way. Sigi way is that we just write it on a piece of paper. Like patient comes, they go to the registration counter, registration is done. Adu matungda, we use different other symbols that defines what kind of process it is. That is called a process mapping. Process mapping can be done, and it should be done for every departments. OPD dana patient la akanda door to drug time. Door to drug time. The patient comes to the door of the facility till the time he goes out after taking a medicine from the pharmacy. That is door to drug time. Door to drug time calculate we need to have this process mapping. That is for OPD. For labor room, for example, process mapping for labor room can be patient tuna lakpa register tauba labor room ma maternity warta prenatal warta ma admit tauba labor room da maze angang pokpa, then postnatal da lakpa, then adi matung da observation da lakpa. All those things are flow ama piba hai tareko. Lab kisu mi malakpa sample collection lauba adogi magi registration tauba. All those things will all have to be in one paper. Stepwise magi different akoina symbols mayama mapira kanda akoina process map tauba poto. That is process mapping. So one thing about quality management is quality policy and quality objective. Details the quality management the high, but just giving you a brief idea. Quality policy hai taragadi, it is just one. For the whole facility, there will be one quality policy, and that is a comprehensive primary healthcare piba district hospital dana specialized service piba at an affordable cost with quality sugumba mayam se akhona quality policy ne haibako. Please remember two words in quality management. One is quality policy, one is quality objective. Quality policy is for the whole facility. Quality policy is for the whole facility. Quality objective is for different departments. Quality objective for OPD, quality objective for IPD, quality objective for lab, pharmacy, maternity, OT, whatever. What is a quality objective is if you have a gap in the checklist natragana noigi miron bi angang pokpa noigi normal delivery gi masing je yamdragadi kamaina 3 months da kone hengalhangadage habido. For example, in the sub-center level, if your telemedicine consultation is poor, you have to make that your objective that in the next 3 months, I will try to improve my teleconsultations from 10% to 25% in the next 3 months. Like this, objective haitaragadi, it will be for different departments. Quality policy haitaragadi, it will be for the whole facility. Quality tools and methods, it's huge. We will do it when we come for quality management. This risk management and clinical governance, this is for district hospital. Hauziki scenario sida, when doctors are being targeted for any kind of negligence, this clinical governance and risk management, if we do it, yam phaba, whether yam kanaba pot ama oiniko, it deals with what happens in a disaster, what to do in a disaster, what to do in facilities that any kind of emergencies ama thok matamda risk ama thok matamda kaidogada gi habse hana loinamak sida frame tawraga thamdoini ko includes in clinical governance and risk management. Clinical governance tadi khoigi ngasai gi magi all administrative oiba pot mayam ama thokla ani ko. So let's see when quality management comes. Outcome indicator, there will be productivity. Please remember outcome indicators the mari like standards. There are 4 standards. Atai the standards amata khandragazu, please remember in the outcome indicator there are 4 standards. 4 standards in outcome indicator. Those are, one is productivity indicator, one is the efficiency indicator, one is the clinical care and safety indicator, and the another one is the service quality indicator. Productivity indicator, for example, how many OPD patients was seen, how many NCD populations, how many NCD cases were seen, how many emergency was done. Efficiency is out of all those normal deliveries, how many was done at the night. ꯑꯩꯈꯣꯏꯒꯤ efficiency ꯌꯦꯡꯉꯛꯀꯗꯣꯏꯅꯤꯀꯣ ꯑꯗꯒꯤ PPH ꯀꯌꯥꯝ ꯊꯣꯛꯄ ꯈꯣꯠꯄ ꯑꯗꯨꯝꯕ ꯃꯌꯥꯝꯗꯣ ꯌꯦꯡꯉꯛꯀꯗꯣꯏꯅꯤ. Clinical care and safety indicator habamga, service quality indicator habamga su later in the outcome indicators which will deal with akona keno tobukanda. So just to have a brief summary, service provision the is the availability of emergency services, availability of ops gynae services, complications management, diagnostic services, blood bank services sugumba mayamse district hospital da laibra harakadweni ko horen. Emergency services pibra, ops gynae services pibra, complications managed tobra, diagnostic services laibra. Diagnostics if akoigi PPP model da Krishna na lobo oiragadi yam phareko. Many things Krishna dagi, Krishna Diagnostics dagi noina external quality assurance tobagi na tagana, you can get many documents from Krishna Diagnostics. At the same time, in-house lab tasu, there are certain tests that needs to be done in-house. IPHS norms ki makhada yauriba 14 tests mandatory emergency da tawgadawbani. Adugumba mayamdo akoigi in-house da laitaba yade aduga mui tawdanaba at least microscope kumbani khangde, stains kumbani khangde, reagents, some basic oiba kharagidi Krishna da depend tawba yade. For all other high-end tests Krishna da tawe highway otherwise lab da in case of sub-center PHC CHC as well as district hospital da aikoigi in-house test so emergency tests kit based card based adagi smear sugumba kharadi tawdaba yadebako in the diagnostic services. The patient rights information IEC BCC TV thamakanda koina e-drive campaign gi pochai kapthokpa natragana awareness ki akoige video kai kai kapthokpa adumba mayam, it will come under this signage citizenship charter. I will show you how what a citizenship charter looks like. It's one of the most important akoige IEC material ne display tawgadova at the entrance of the facility where all beneficiaries can be seen. All beneficiaries can see. It will include, as I have said earlier, patient key rights and responsibilities, complaint key grievance redressal mechanism, staff key strength, how many doctors, how many nurses, how many MPW, how many dressers, all those things will be written there. What kind of services, when is the NCD OPD, when is the IOPD, when is the gynae OPD, all those things needs to be displayed. Telephone number of the in charge of the facility needs to be displayed. There are some IC materials like telemanaski phone number, police ki phone number, then noigi kenogi phone number, nearest referring facility ki phone number. All those things will be displayed in the citizenship charter. Inputs, as we all know, drugs, diagnostics, HR, consumables, infrastructure, HR, drugs, consumables, equipments, instruments, and competency. Shugumba mayamse inputs sa yengdoini. Support services the we all know non-clinical oiba diet, linen, medical records, statutory requirements. Statutory requirements high taragadi. Please remember, a facility needs to have the biomedical waste certification from the common biomedical waste treatment facility like CIJA. If it is more than 75 kilometers, they need to have a license from the State Pollution Control Board, which gives them the permission to dig a deep burial pit and a sharp waste pit. 75 kilometers ki beyond the laikita agadi shija or common biomedical waste treatment facility na collect biraroi, they will need a separate deburial pit as well as a sharp pit. For that, a license needs to be obtained from the State Pollution Control Board. Then fire for primary level of facilities, the fire certificate say it's not needed. It is just the declaration form that our staffs are trained for firefighting. We have done a mock drill. A self declaration is enough. Whether I adu form du sohren yengange koigi kanoda fire extinguisher lairaba. We have to declare that we have one or two fire extinguishers. We have done mock drill, and that's enough. Fire safety certificate is but for the level of CHCs and district hospitals, fire certificates, it needs to be procured from the fire department. And they need to have check karai jagada fire extinguisher kaya pangadobano for the level of district hospital and CHCs. Water, electricity, medical gas, RKS, public hearing, outsourcing, all those things will come under support services. Clinical services, the high giba general ne, specific ne, aduga atopa sumba STG gumba national health programs kumba adugumba mayamdo will see in the clinical services. Infection control, as we all know, it is about hand hygiene, personal protective equipment, instrument sterilization, environmental sterilization, and biomedical wastes. Quality management, quality team form toba, quality circle form toba, patient satisfaction survey, employee satisfaction survey form toba, see all monthly patient satisfaction survey, employee satisfaction survey toba, standard operating procedure frame toba, especially for PHC, CHCs, and district hospitals for every department. Aduga sub-centers kina, we call this work instructions. Quality tools and quality method we will do later. Quality management ta adung nasagi prescription audit, child death audit, maternal death audit, sugumba mayamse audit mayamse loina lakani. Then is my voice clear, or should I connect another microphone? Clear oidabra aigi voice se tang feedback tang pibira. If not, then I will use another microphone.
Yep. Please, I'm. You're audible at my end, but at Chorachandpur, I think the sound is little.
Okay, okay.
Steve, can you give feedback on the sound audio?
And Senapati SJ's mouth. Is it audible now?
Yeah, audible.
Okay, okay. How is it at Sisipur, and how's the sound? Steve, are you there? We'll we will carry on then, Cecil.
Okay. So then outcome indicators, the footfall in the hospital, all those like data, facts and figures, monthly outcome indicators have to be calculated monthly. So every month outcome indicators will be calculated. It's all about facts and figures that we about the services that we give in that particular month. So these are the basic brought 8 areas of concerns and their standards where we assess a facility. So again, just to summarize, service provision is about availability of functional services. Patient rights is about accessibility, acceptability, and affordability. Inputs is about HR, medicines, equipments, infrastructure availability. Support services is all about the non-clinical indicators, finance, RKS, linen, drug, all those things, management. Clinical services will come in the area of concern. S, infection control, biomedical waste management and infection control, instrument sterilization, biomedical waste, all those things will come under infection control. And this we will do in elaborately. Quality management system we will do elaborately tomorrow. And then outcome indicator is just the report card of the facility. So as Tamo was saying before we began with our session, when we assess something, we look in three levels. One is the structure, one is the process, and one is the outcome. Outcome, as you all know, it is just the report card of that facility. How much the service that we have given, that will reflect in the outcome indicator, that is area of concern H, as well as some part in area of concern A. But let's see what a process is and what a structure is. Structure is the infrastructure, availability of drugs, diagnostics, training of all these things will come under infrastructure. Landscaping, most part of inputs like how much consumables you have, how much drugs, diagnostics you have, how beautiful is your facility, how much landscaping is done in your facility. All those things will come under the area of under structure. Process deals with the service that we are providing to the beneficiaries and their records. If we are providing services to the beneficiaries, then we are supposed to record everything on registers, on files and everything. All those things, the services that we are providing comes under process. Let's see in the 8 areas of concern, which ones are structures and which ones are process, which ones are outcome. Let's say this orange ones, 1, 2, 3, 4, 5. Out of 8, 5 are already process, 2 of them are outcome, and only one is structure. This makes 79% of our effort should be in process. That is patient rights, support services, clinical services, infection control, and quality management. The part where inputs is where is the availability of drugs and diagnostic, beautification of the facility, landscaping, all those things that costs money, which comes under inputs. It is only 8% of NQAS. What we are trying to say is, please don't think NQAS is very expensive. Please don't think NQAS is very tough. please don't think that and we don't have that much of funds, we don't have that much of infrastructure to certify for NQAS. NQAS is all about process. Process is patient rights. To have the IEC materials displayed in the facility, to have the directional signage, to have the consent forms taken, to have just a small bar installed in the stairs as railings. We have support services, which is all about documentation about finance, documentation about linen management, documentation about buffer stock, reorder level of pharmacies, stock management of all these things, which comes under supports. Clinical services all about technical knowledge, which can be very much improved with proper training and capacity building. Infection control processes we are already doing, and it comes better and better with capacity building and training and with some more of our documentation. And last is the quality management part, which is all papers. Quality management is all papers. It is framing of the SOPs, which doesn't cost money, which forming of a quality team, which doesn't cost money, which use of quality tools that doesn't cost money, use of quality methods, taking patient satisfaction, all those things does not cost money. The part where money is or any funds are usually taken up is the inputs part, which is only 8% of NQAS. I'm not saying key financial support is not needed while implementing MPLUS. It is, but then there are many other parts in NQAS where we can score a lot of marks without spending money. If we are motivated, if we sit down just to have with our team and start, framing the policies, if we start, maintaining the documentations. So NQAS is predominantly a process-driven standards. We have, this is called a Donabedian model. This is called a Donabedian model of quality of care, that is structure, process, and outcome. On which outcome, which is the facility ki, the report card makes 13% of the 13% of total NQAS, and 79% of the NQAS is total process, which is all documentation, records, and patients' rights. So I think everybody must be familiar with the assessment methods. Assessment methods, we have 5, out of which one is observation, second one is staff interview, third is record reviews, fourth is client interview, and fifth is patient interview. Observation is when a assessor comes to the room and sees whether the room is clean or not, without any documentation, without anything. He just comes, he sees. If he feels that it is clean, he will give marks. If he feels that if it's not clean, then he won't give marks. Secondly, if he just comes and in an IPD, suppose it was supposed to have 2 fans, and then he just comes and he sees there are 2 fans, then he'll just give marks. That is observation. Staff interview is about when an assessor comes and asks whether the bed sheet was changed today, whether she knows the process of giving an injection, can be asked how the biomedical wastes are being segregated, all those things. Interviewing the staff, that comes in staff interview. Record reviews is about anything that has happened before, like OPD registers. From the OPD registers, we will know whether night service OPD is available at the night, or emergency services, which is it provided at the night. If the facility declares that they have done 24 deliveries in the last month, then it will be the records that we check to see whether the deliveries, some of the deliveries were conducted at the night, or was it all during the daytime. So things like that. This is record reviews. We will see from the records. Client interview is about whether this hospital was clean to any patient who is staying in the IPD, that we can ask bedsheet change tawgrabra, nga sigi kano se, nga sigi floor se clean tawgrabra. ngarang toilet chapa matamda ising taramra taramdabra, toilet se haujikta sengira daily gi sengbra, all these questions can be asked in client interview or patient interview. I would like to also just add something about patient and client. Patient satisfaction survey, client satisfaction survey. Patient is the patient who is sick, client is the person who is coming with the patient. It can be mother, father, brother, anybody who is, we call it in our language, this patient party. Patient party the gisu, we will take feedback. Patient masa the gisu, we will take feedback. Different, when we take patient feedback, we will try to take feedback from all age groups, all ethnicity, and 30 say we will take some from patient party, that is client, some from patient themselves. So these are the assessment methods. To have this thing, or just to have a brief about the observation, that is, when we observe the display of signage, work instructions. Okay, so these are the observations. This uh, signage thelamba, directional signage, facility layout, all those things can be observed. Staff interview competency, how do you take BP, quiz on the staff on how to manage this spill management, mercury spill management, all those things. A staff, nurses especially, are supposed to be able to give awareness to the patient. So we will ask them, if any patient with diabetes or any cases of NCD comes in, then what are the things that you tell them for awareness of this particular disease. Those can be asked to the staff nurses. And the next is the record reviews. As I have said earlier, it's about things that have happened in the past, or things that we cannot just assess at the spot. Patient interview and client interview, patient and their party, client, both of them, to have their feedback, to have the comments on cleanliness, hygiene, and all those things about the ward. We can ask them about attitude of the doctors, attitude of the staffs, are they empathetic, or all those things can be asked in patient and client. And comes the scoring rules. Scoring rules, I think everybody must be aware of it, those who have participated in Kayakalp and those who have implemented a bit of NQAS. In a checkpoint, if let's say if uh, in a checkpoint there are certain measurable elements given, like let's say, I'll just show you a here. Let's say here, this is the compliance part where we need to give the score. Score is 0, 1, or 2. There is a question, assessment score. What is the assessment score like in NQAS? It is 0, 1, and 2. If out of all this, if out of all this, 49% of them is available, then we give them 0. I mean more than less than 49% means out of 10. Let's say if out of 10, if 4 is available, then we give them 0. If 5 or 6 and above out of 10 is available, then we give 1. If 10 on 10 is available, then only we just give them 2. So 0 is 0 to 49%. 4 about 6 to 10 is 5, or 6 to 10 is 1, and 2 on 2 is 10 on 10 is 2. So in the means of verification, if we see like this, you have to just count, nothing more, nothing less. If the checklist asks for something, then just focus on that thing only. Like you don't need, even if they say general medicine services, if the general medicine doctor is not available, we are not concerned about it in this particular checkpoint. We are just concerned about whether these cases are being handled. It does not, the general medicine services, it does not ask whether sister is available, medicine doctor is available, if the doctor trained or not trained for snake bite or malaria poisoning. They have not asked for anything here. So just please focus on the checklist literally. They have asked for it like about 15 points here. If more than 7 is there, then you give 1. If 15 on 15, then give 2. If it is more than 6, then just give 0. Sorry, 8. Okay. So that is how we score in the checklist. These are very simple, I guess. It's been knowing. So let's go to the department wise. Okay. So now let's go to the technical session. In a district hospital, as per NQAS, we assess in 21 departments, out of which 6 departments are mandatory. 6 departments, if we are applying for NQAS, then we will apply for 6 department at least. The departments are accident and emergency or trauma care center, OPD, labor room, maternity ward, SNCU, pediatric ward, hemodialysis, NRC, IPD, maternity OT, postpartum units, pediatric OPD, ICU, laboratory, radiology, pharmacy, auxiliary, mortuary, general administration, and blood bank. These are the 21 checklists, 21 departments which we can assess in a level of district hospital. But 6 of them are mandatory. We would say at least 6 departments. At least 6 departments. Just to have a suggestion to you all from the district hospital, I would suggest you choose OPD, labor room, maternity OT, IPD, general administration, laboratory, pharmacy. These are the 7 easy departments that you can certify with. If you try to focus on these departments, you will also be certified with Lakshya also. It's very easy, and these are the things a general district hospital usually works also. Accident and emergency, if you can do, it's good, but there are certain parts which is a little bit challenging. Otherwise, if you can do accident and emergency, and if your district hospital has a good trauma care center, then you can obviously opt for accident and emergency. On top of this 7 departments, you can always opt for other departments as well. I'm just talking about the easy ones because laboratory is easy, pharmacy is easy, general administration, it is all about paperwork. It just have to be sit down with the all respective heads. OPD is easy, IPD, maternity ward, maternity OT, and labor room. If done together, you will certify with Lakshya as well as NQAS. I would also like to add, if on top of this, if you can, you will get lots of incentives if you can target this Muskan also. These are not very easy. If you don't have NRC, it's okay, just you can just leave it. But if you focus on SNCU, pediatric ward, and pediatric OPD also, then you will be certified with NQAS, Lakshya, and Muskan. If you want to leave all this, that's also fine. If you can, if you want to do labor room, maternity OT, SNCU, pediatric ward, pediatric OPD, and it just comes 6 also, that's also fine. At least 6 departments is mandatory out of the 21 departments. I would request, when you are choosing your department to assess for NQAS, please choose like the departments which are interconnected with NQAS, Lakshya, and Muskan. Okay, so these are the departments. In the district hospital level. Please choose out of this. Six is mandatory, and it is the least number of departments that can be assessed. However, if you keep on increasing the number of departments, your incentives will start to increase, because with only six departments for 100 bedded or a 200 bedded district hospital, or a CHC with 330 or 50 bedded, with six departments, the incentive amount is not that impressive. Next, I would like to go to the CHC checklist, which have 12 departments or 12 checklists, on which previously there was only six mandatory departments, but now they have made it to nine mandatory departments. Here also, I would suggest OPD, labor room, maternity OT, pharmacy and store, laboratory, and general administration. These are easy ones if you have operation theater. Here, no, nine departments is mandatory. They have this OT, they have this auxiliary services, and accident and emergencies. These are the mandatory departments. OT, let's say OT, if you don't have OT, what the NHSRC says is, first try to certify all this first. Try to certify whatever you can: laboratory, general administration, OPD. These are easy ones. You can work on it, and you can get 70-80% on this if you just work a little bit more. For operation theater, if your facility does not have operation theater, it's okay. You just first certify all the other departments, all the 8 departments, and then we need to write a letter for customization of checklist. And in this customized checklist, there will be only 2 kinds of surgeries, that is ophthalmic surgery and family planning surgeries. Family planning surgeries, you don't need a doctor also. We can hire doctors from some place else, from a district hospital or so. We can have the OT for cataract surgeries and family planning surgeries. For now, there is no customized checklist for OT, but if you are ready for this 8 departments, whenever you are ready with the 8 departments, we will send a letter to the NHSRC. They will customize a checklist and send it to you in 2 weeks. That will be a very easy operation theater checklist. So please keep that in mind. Please do not think like OT is included, so we will not be able to do NQAS like that. Leave the OT for now. Please focus on the other departments. When other departments are ready, please let us know. Let's have the assessment. Then we will write a letter to send us the customized checklist for your particular facility. And in 2 weeks, they will send a customized checklist that has only family planning services, an OT, which deals with family planning surgeries like vasectomy and tubectomy and cataract surgeries. Now, please do not think that in that particular OT also cases will not be taken up or you won't have patients. Don't think that way. NQAS usually see the preparedness of the facility. If you don't have any patient for cataract surgery, that's fine. You just need to have the necessary infrastructure, documents, drugs, diagnostics that you need to have uh, for that particular setup. If you don't have patients also, that's fine. But just we need to have the preparedness of OT to deal with the family planning services and cataract surgeries.
Still,
Yes.
I have a question. See
Mm.
now, for Perzol CHC, we don't have operation theater. At the
Okay.
same time, the optional is family planning and ophthalmology surgery. Even then,
Huh.
we need these two services. Why
Huh.
don't we put inpatient department instead of OT?
No, I'm sorry. That's why I just take this IPD. IPD is already this thing. IPD is
Hmm.
already mandatory.
That's what. Okay, okay.
IPD is already a this thing mandatory department, but OT comes under a mandatory department. So what they are saying is there are many in all over India. There are many CHCs non-FRUs where OT is not
Yes.
available. So they also know this issue. They have not yet come up with the customized checklist, but there are many CHCs in India who have done this thing, who have already assessed for the 8 departments, and they were
Okay.
just short of this OT. And they have written to the NHSRC, and they have sent a very simple OT checklist. And then
Mm.
many of the CHs have already been certified for NQAS now.
Okay, one more thing, I have a question
Hmm.
regarding the operation theater. Under this one, recently I proposed the PIP,
Ah,
maternity OT. So I
hmm.
have talked with the maternity department also, like
Hmm.
also they say that they are going to put up in the file.
Okay, okay.
In the customized, will it be okay? Like if we go for this maternity OT, would will subside all the operation theater checklist?
No, no, no. That will come later. I'm just talking about a different setup here.
Okay.
Mhm. Let the construction of OT and those PIP, let it go on. In the
Mm.
meantime, I'm just talking about to have your facility certified for NQAS. We'll have a different setup. It'll be a very
Mm.
small setup OT, not like a proper OT setup. It'll be more like a minor OT setup where
Okay.
infection control and all those things will be implemented, and
Mm.
some cataract surgeries and some family planning surgeries can be done.
Okay.
Mhm. All right. So these are the 12 checklists, 12 departments of community health center. Now let's go to primary health centers. Primary health centers is very interesting. Primary health center, I would say, one of the most uh, highest incentive. Okay, 3 lakhs. If you certify this 6 departments, these are all mandatory departments. None of the facilities, if because since am I audible? Tamo, am I audible?
Yeah, yeah, yeah.
Okay, okay. So for primary health centers, I would just give you this, highlight this incentive part. I will be talking about incentives in the later slide also, but just this is very interesting. District hospital or community health centers, even though they have like a lot of beds, even if they have lots of this thing, their incentives will be up to a maximum only when they apply for all the departments. Community health centers, they will get the actual incentive only when they apply for the all 12 departments. District hospital will get the total incentive that they are supposed to get only if they apply for 21 departments. But see, for primary health centers, there are only 6 departments. 6 departments, if they are certified, they will get 3 lakhs. Like this is the total amount a PHC can get, and they will get this 3 lakhs if they certify in these 6 departments. So incentive wise, primary health centers have an advantage on this. So the departments PHC should certify are OPD, labor room, IPD, laboratory, and general administration. National health programs is not a department, but this is a different checklists where many things can be done with the help of their subsequent CHOs or sub centers. There are about 14, 15 national health programs that they need to deal with. They need to have accept the referrals from the sub centers, need some awareness outreach campaigns, immunizations, all those things. And then this is easy for a PHC. If any of the districts have UPHCs, UPHCs have 12 checklists, but please don't worry. These are not departments. These are very small checklists. Even though they are saying 12, these are very, very small checklists. These are not departments. People used to say, like, in PHC, which is bigger than UPHC, they have only 6 checklists, and in UPHC there are 12 checklists. It's not like that. In UPHC checklist, every single checklist is very, very small. UPHC also, without beds, they will get 3 lakhs. Then in sub-centers, coming to sub-centers, 12 expanded package of services are supposed to be provided to the community. Previously, there were only 7 mandatory packages, but now that has been taken off, and they need to be certified for 12 service packages. 12 service packages will be done. The assessment will be done. One advantage is that the assessment for sub-centers can be done and will be done virtually. So what we want to show to the assessor, we will be showing it to the assessor. Whatever documents, whatever registers that the assessors would like to see, we have the advantage of not showing the whole register to the assessor. We will be showing them whatever registers that we have made, the specific pages that we want to show to the assessor. Even if the assessor asks for 20 registers and 20 policies and 20 records, we will be showing them whichever pages that we would like to show to them. So this is another advantage of assessing virtually from the facilities side. But then, yes, through a virtual assessment, a CHO needs to have a lot of knowledge about functioning of the facility, technical as well as non-technical, clinical as well as non-clinical, because the assessor will be asking them a lot of questions about management protocols. Let's say, for example, elderly palliative, how do you manage those patients? In case of emergencies, how do you manage a case of snake bite? All those things may be asked by the assessors, so it needs to be a little bit more oriented on the clinical as well as non-clinical side. So but it's good that sub-centers, their assessment is being done virtually. It is easy, it is very much favorable to the CHOs, because they can show the assessors whatever they think is beautiful, whatever they think is presentable in their facility. So now let's go to checklist details. So accident and emergency, this is for district hospital. I just want to have a brief idea on, like, what do we do, what do they assess in the individual departments. Accident and emergencies, about dedicated emergency department is necessary, and all those infrastructure, drugs, diagnostics, HR, and functioning, all the services, what all kinds of services, poisoning, may it be injury, may it be trauma, all those things will be assessed in case of accident and emergency. Labor room comes under Lakshya. Labor room and maternity OT comes under Lakshya. So it is one of the most important department that a PHC, CHC, or district hospital should include in their assessment, because it is easy and it is scoring. So in the labor room, there will be labor room and its auxiliary area, like nursing station, waiting area, recovery area, septic labor, eclampsia, all those things will be assessed. Outdoor department is mandatory, and outdoor department will have the ICTC and ANC clinics as well. ICTC, even though they test for HIV, they are not included in the laboratory, they are included in the outdoor department. OPD may have NCD OPD, gynae OPD, ophthalmology OPD, whatever specialty OPD can be done. But there is a trick here. If in your center, CHC or district hospital, if you do not have that much of space for every specialty OPD, you can identify, like, Friday is for medicine OPD, Thursday is for gynae OPD, Wednesday is for RBSK. RBSK, especially like adolescent friendly clinics, usually opens after their school hours, so they can continue, like, from 9 o'clock to 3 or 9 a.m. to 3 p.m. is the NCD OPD, and 3 to 5 is the adolescent OPD, like that. So if you don't have that much of infrastructure, or if you don't have that much of rooms available, to have to cater the needs of the OPD, then you can mix the OPD. You can call them like specialty OPD, and you can say like Thursday is for ophthalmology OPD, then Wednesday is for this gynae OPD, Monday, Tuesdays and Fridays for pediatric OPD, like that. You can manage. If you don't, if you have space, then it's okay. If you don't have space, then you can just mix it. In case in an IPD or anywhere, if they ask for a sister station, they are not asking for a separate dedicated room for sister. They are asking for a separate table that sisters can work. When you go through the checklist in IPD, in inpatient department, they may ask for separate sister station in the IPD. Please do not think कि in the IPD they're supposed to have a separate room for sister. You can just keep a table, keep some files, and the place where a sister will be able to record the vitals and do the paperwork on that table, load some drugs. That's it. So you just have to you have to literally read what the checklist says. If the checklist doesn't say particular thing, then we are not supposed to assume anything. So family planning, dispensary, pharmacy checklist. In the pharmacy checklist, there are two kinds. One is the drug dispensing unit and the drug storage unit. Drug storage unit is the part where we store all the drugs, and drug dispensing is the part where we take out some of the fast moving drugs and give to the patients, just like that. Then maternity wards. Maternity ward can be included, may not be included. Maternity ward is usually not included in many of the facilities that I have seen till now, because maternity ward is not included in the Lakshya checklist. Also, Lakshya is concerned about labor room and maternity OT. Then indoor department is it's a mandatory unit. Indoor department, you have to have a male and female separately, toilets included. All those things are assessed in the indoor department. Then nutritional rehabilitation center, if it is there, it's fine. If not, this can be neglected. In Muskan also, if you don't have nutritional rehabilitation center, you can try for pediatric ward, pediatric OPD, and the other SNCU like those. Pediatric ward is for Muskan. If you can do for pediatric ward, if you have a good pediatric ward, then you should go for it, because that will help you in further incentivization under Muskan initiative. Then sick newborn care unit. Sorry, this should be special newborn care unit. Special newborn care unit is for district hospitals. If it's there, you should definitely apply for it. This will help you in more incentivization of the facility. In case of CHCs, you should be having newborn stabilization unit, which is a smaller version of this special newborn care unit. This SNCU and NBSU is not meant for primary health centers. It is only for CHCs, SDH, and DH. Intensive care units, like nowadays, I think tele ICU concept is going on very well. That tele ICU can be presented as ICU in case of NQAS. So if you have a very good tele ICU setup, then that can as well be applied for NQAS. Other than that, I have seen in District Hospital Chandel, their hemodialysis unit is functioning beautifully. So whichever department, if you think, whichever department you think will be is functioning beautifully in your center, you can just include those. OT, OT, I would say for any district hospital, while choosing the department, if OT as well as maternity OT is being done in the same OT, then if possible, I would suggest to have a different OT for maternity OT. If not, that also fine, but please assess for maternity OT. So that will be more beneficial, because that will be included in your Lakshya checklist. So instead of assessing OT, please assess for maternity OT. All right, postpartum unit, blood bank, laboratory, radiology. Radiology deals with X-ray, ultrasound, CT scan departments. If you don't have CT also, it's fine. You will just lose some marks, but you can as well apply. But if you are applying for radiology, you need to make sure that AERB licenses and PCPNDT licenses are must. They have to be shown, because for X-ray, AERB license, for ultrasound, you need to have the this PCPNDT license. Pharmacies have a drug dispensing counter and drug storage area. Auxiliary services. People usually ask, what do we cover in auxiliary services? Auxiliary services is about laundry, dietary, and medical records department.
I'll just go down.
Dietary.
Okay. Yeah.
Can, if anybody, can you please mute yourselves, please? Can please mute yourselves? So auxiliary services deals with laundry, dietary, and medical records department. Dietary, as laundry, I guess every district hospital must be having a laundry. I'm talking about this CHCs. If CHC doesn't have a laundry, then you can outsource it to any agency. They will ask you for any. They will ask you for a memorandum of understanding, and you can outsource your laundry to like any agency outside. Dietary, as I've said earlier, for dietary, uh, you don't need to provide dietary food to all the inpatient patients, but pregnant women is must. And if you provide diet to pregnant women, you'll get a lot of good scores. Medical records department is there. Mortuary, hemodialysis usually people don't apply, but some of the facilities like district hospital Chandel, whose hemodialysis center is working beautifully, they have applied for hemodialysis. General hospital administration is one department where it is all about documents, all about policies, all about SOPs, quality manual, all those things. Then even tracking records of fitness certificates issued, all those things, MLC certificates, all those things. I would also like to just add just one thing here to all the medical officer in charges who are present today. Please try to keep a register of all the fitness certificates issued in the facility, if not done till now. Because fitness certificate, how many was issued, and how many birth certificates issued, how many death certificates issued, how many fitness certificates issued, MLC, all those things will be coming in this NQAS, and we need to produce the documents for the past 3 months documents of the number of certificates issued and to whom. And I think it's a good practice to have a specific format of physical fitness certificate, like the name, the demographic details, like name, age, sex, address, and everything written at the top. The facility, the on the facility letterhead, and fitness certificate while issuing. Please frame a format. If you want, we can provide that format to you as well. On that format, vitals and everything are supposed to be written. There should be a specific, like the referral format that we have, same like that. We need to have a format for the facility to provide physical fitness certificate to the patients, so that if any doctor provides an physical fitness certificate, that has to be in that particular format, and that should be recorded on one register, on which date and which time, or on what conditions was this physical fitness certificate issued. That comes in hospital administration, and that comes in your quality management as well, in while assessing your facility. This is for primary health centers, UPHCs, CHCs, and district hospitals. So measurement system for facilities, to have a brief idea, you can take a screenshot of this as well. I will be sharing the slides, but this is just for your knowledge and just for theoretical purpose. As we can see here, there are 75 standards in district hospital. CHCs, there are 65 standards. PHC, we have 50 standards, 35 standards for UPHC, and 48 standards for subtype A, 50 for subtype B. I would like to point out here that subtype A means any subcenter where delivery is not conducted. And subtype B means any subcenter where delivery is being conducted. Labor room is available in subtype, so that's why there are 2 standards extra for deliveries. However, in case of subtype A, there are only 48 standards. You don't need to worry about all these measurements, measurable elements and all those things, but please, for theoretical purpose, please know how many standards are there. And in district hospital, there are 21 departments or 21 checklists. CHC 12 out of 12, 9 is mandatory. District hospital out of 21, 6 is mandatory. For PHCs, 6 on 6 is mandatory, 12 on 12 is mandatory. Here, only one department or only one checklist for subcenter, so that is the only one. So these are the measurement system for level of facilities for NQAS. Let's talk about final assessment score and their incentivization. When a district hospital is assessed for NQAS, this is the kind of score that the checklist will give you. This is assessed for all the 21 departments, but if you are not assessing maternity ward, if you're not assessing NRC, if you're not assessing all this, this won't come out and the hospital score will come out here. Maternity, OT, and labor room score will come out here. Muskan, pediatric OPD, IPD, NRC, and SNCU score will come out, like they will have an aggregate score which will come out here. Maternity, OT, and labor room score aggregate will come out here, and this will be your hospital scorecard. The hospital score for state certification should be 65%, and for national certification should be more than 70%. There are certain criteria for certification of a public health facility, which I will be talking in my subsequent slides. Area of concern wise score will also be seen, and in this area of concern wise score for national level certification, it should be more than 70%. For state certification, it should be more than 65%. This is the area of concern wise score. Next, we will see the departmental scorecard. Every department that we assess, it should be more than 70% for national level for national level certification, and for state level certification it is supposed to be 65% and above for every single department. Let's say labor room should be more than 70%, maternity OT should be more than 70%, OPD, IPD, lab, pharmacy, all is supposed to be more than 70%. Lastly, there is a thing called standard wise score. Standard wise score, it should be more than 50% for every standard. Every standard you need to score more than 50%, and for state level certification you need to have a score more than 45% of state. For state certification you need to have this every standard score more than 45%. All right, so we see, well, first we see the hospital score, which is supposed to be more than 70% for national certification and 65% for state level certification. Area of concern wise score, 65% for state, 70% for national. Departmental, every department is supposed to score more than 70% for national certification, and state level certification would do with 65. Standard wise score should be more than 50%. Every standard, A1, A2, A3, A4, A5, all this you should score more than 50% and more than 45% for state certification. Now this is the criteria for national certification, which I was talking about in my last 2-3 slides. Aggregate score of the facility should be 70%. Score of each department should be 70%. Score of each area of concern should be 70%. Every individual wise score should be 50%. And they have given some A2, B5, D10, which is about reproductive and maternal health. B5 is about your statutory licenses. Sorry, B5 is about your facility financial entitlements, and D10 is about your statutory licenses like AERB licenses, your PCPNDT, your fire safety, your fire safety, your biomedical waste certificate. All those certificates is about D10. So score of standard is only these 3 standards you need to score 70. Rest all you can score just 50%, and that's fine. For CHC level, it's the same thing, 70%, 70%. A2, B5, D8. D8 deals with the same thing as the district hospital, but because of some standards, numerical, that's the reason, but the logic is same thing. D8 also deals with the certifications. Individual wise score is 50%, and at the end, patient satisfaction survey for district hospital, it should be more than 3.5 out of 5. For SDH, it can be 3.2 out of 5, and for PHCs, it can be 3.0 out of 5. I think I've made myself clear. PSS is very, very important. PSS is not only important for NQAS, but it is also important for Kayakal, because even if you score a very high score in Kayakal, if your patient satisfaction score is less, that's gonna bring down the total score to a significant amount. So please focus more on the patient satisfaction score. Likert scale, if you give in Likert scale, it's like 3.5 out of 5 in district hospitals, 3.2 in CHCs, and 3.0 in UPHCs. Sorry, CHCs 3.2 and PHC 3. If you calculate in percentage, 70%, 65%, and 60%. So we can have this, can take a screenshot of this, so that while preparing, you can just keep on checking what the national certification would mean. This is for arm sub centers. Arm sub centers is a little bit different. As we know, there is no department in sub centers. There is only one checklist. We will be assessing that the score of the overall score of the health facility is 70%. Score of each service package is more than 70%. Segregated score in each area of concern should be 60%. Then score of standard 60%. Individual standard wise score is 50%. Okay, can have a screenshot of this, and then we can while implementing your NQAS, while assessing your checklist, then you can just keep a track of this. For state certification, from the national certification, 5% concession is there in all the criteria. Which was 70, it has become 65. What was 60, it has become to what was 70, it has become 65. What was 70, it has become 65. What was 60, it has become 55. So 5% concession in all the criteria is there. These are the incentives under NQAS, which I just wanted to show how much you can calculate how much incentive amount you would get. As I was saying, let's start with PHCs first. Let's not go to the district hospital. I'll come to district hospital. For PHCs, 3 lakhs is direct, 3 lakhs without any, if there is certification without any conditionality, a PHC will get 3 lakhs as incentive, and out of this 25% is your staff incentive. You can the staffs can go to a picnic, they can go for a trip, whatever. Just same like Kayakal, like 20%, 25% of this amount is yours. And in audit also, you can just say like we have use it for staff welfare. It's fine. Then UPHCs without beds is 2 lakhs if UPHCs is without beds. And for sub-centers is 18,000 per service package. That is 18,000 into 12. This will be your incentive amount. Now, why I wanted to focus more on this district hospital is because if you have 100 beds in district hospital or a CHC, if you have 100 beds, then it's going to be like 10,000 into the number of beds. Okay, 100. But this has to be like multiplied by the number of departments that you are assessing, like let's say 6 out of 21. So it becomes significantly less if you are assessing only 6 departments. If you are assessing for more than 6 departments, then the incentive amount just comes up. So let's say 100 bedded, 10,000 per bed, into, if we assess for about 10 departments out of 21, then this is an impressive incentive. So it's up to you. If you can assess for more than 6 or 10, more than like 6, 7 departments, the incentive amount will be good. If it is only for 6 departments, then it will be just 6 by 21. So that becomes a very like one third of the actual amount that you are supposed to get. Same thing for CHCs. Think I'm clear. So just next, there are certain documents before we apply for NQAS. There are certain documents that we need to submit to the Saksham portal before applying for the national assessment, and these are the documents that we need to submit. These are the documents that we need to submit to Saksham portal before. Can please
Mute, please.
All right. So let's see. For district hospital, we need to have all this quality team meeting minutes. Quality team meeting minutes are necessary. Departmental standard operating procedures are necessary. Quality improvement manual. I'll be sharing with you all the format for quality improvement manual. You can just customize it according to your facility. Then there are certain policies in district hospitals that you need to submit. Those are the condemnation policies, antibiotic policies, social, culture, and religious equality policy, privacy and dignity and confidentiality policy, consent policy, referral policy, quality policy. You might think there are lots of policies that needs to be submitted for NQAS, but please don't worry. You can get it all from the State Quality Assurance Unit. These are all framed. These are all framed, and these are you just have to customize it as per your facility. These are all framed. Just a second, please. My chair on. So condemnation policy, if already framed for the community health center or district hospital, then that's fine. Antibiotic policy, we can implement the ones that the RIMS and GENIMS is using, or we can have it, customize it for our facilities. However, all these documents, all these policies, SOPs are already framed, so you don't need to worry. You just have to take some time out to customize this as per your facility. Then scores of last 3 patient satisfaction surveys. These are the analysis format for 30 patients, patient satisfaction survey, which was done for 30 patients. It's in an Excel sheet, which is auto calculated as well. Key performance indicator. As I have mentioned earlier, there are 2 things called, one is the key performance indicator and one is the outcome indicator. Outcome indicator is your area of concern H, which is there for every department. This is not the area, this is not the outcome indicator that they are asking. They are asking for key performance indicator. This is a separate Excel sheet, which we have to submit. This is a facility level data, not the departmental level data. This is a facility level data. Okay. Give me just 2 seconds, please. Sorry for that. So these are the documents that needs to be submitted by submitted while applying for national level application through Saksham portal. However, all of these are not required at the time of state certification. State certification, for this we need the KPI as well as the PSS first.
Dr. Cecil,
Ah,
we will go for lunch after 5-10 minutes. Is it
okay,
okay?
okay.
Okay, please.
Yes, I'll just show the documents necessary for armed sub-centers, and then we can go for lunch. So these are the list of documents for virtual certification of ARM. Let me stress again, this is for virtual certification. For physical certification of ARM, it is different. For virtual certification, it's different. For virtual certification, it's kind of short. So what we need is the assessment record. Assessment record, I have said earlier, it is supposed to be the assessment which is done by the state. Done by the district, not the state. I'm giving more and more emphasis to this word. Key for sub centers and primary health centers, state certification will not done by the state. It should be done by the district. Just as for Kayakalp, for primary PHCs and sub centers, the certification level is at the district. Just like that, for state certification, for PHCs and sub centers, certification authority is at the district level. So they are asking for the district level assessment, which is verified by the state. Verification is like we just have to verify whether the scores, the calculations and everything are correct at the state level. That's it. And we will need the quality teams meeting minutes, work instructions for the 12 packets, as well as the work instructions for rapid diagnostic kits and the biomedical waste, quality policy of that facility, 3 months record of the patient satisfaction survey with CAPA, corrective and preventive action, and availability of a system of biomedical waste management. This I will emphasize more on the infection control part, because for sub centers it is very easy to have the certificate for biomedical waste management, because they do not need to tie up with any authority like State Pollution Control Board or biomedical waste treatment facility. If the PHC, if the linked PHC is kind enough to take their wastes for disposal, then it works for them. Then last 3 months of outcome indicators, which is the KPI. KPI and outcome indicator for sub-centers is the same thing, because they have only one department. For PHCs, CHCs and district hospital, outcome indicator and KPI is different. But for sub-centers, outcome indicator and KPI is the same thing, because they have only one department and only one checklist. Then they will need to submit the stock register. They have a specific format called as the stock report, on which the last 3 months stock indent, received, issued, and current balance is all recorded in that format. That needs to be submitted. And the essential medicine list, which is a memorandum which is issued by the state mission director. These are the documents that needs to be submitted. We can think of these as filling up the forms, and these are the things that needs to be submitted before applying for an exam. So at least these should be prepared before a national assessment. So all these records for virtual for sub centers are supposed to be submitted at Saksham portal at the time of national applications. So these are not very tough ones. These are, if you can just start from today. If you can just start from today, in the next 3 months, you will have data. You will have paper. You will have documents for the last 3 months. So you don't need to prepare a lot of documents for the past like 5-6 months. If you can just start today, in the next 3 months, you will be having documents for the past 3 months. So with this, I'm gonna wind up the pre-lunch session. Thank you all for patient listening. Maybe I think tamo minute kya talk si kya
Uh,
chance.
we'll join in 1:45.
1:45. I guess it's fine.
150 will start.
Okay. And from the participant side, if there is anything, any feedback, any positive or negative, if you want me to slow down or go faster or include some more topics that you would like, you please drop it in the message. Thank you.
Still,
Uh,
I have one question again.
mm,
Get a certificate for pollution control board. 3
mm.
years back, the state are telling us that they are planning to get a certificate for all the targeted facility, not the
Yeah,
facility or the district has to run for it, but the state will run for all the facility and then will give it to us. That is what
yeah,
they
yeah,
say.
yeah,
So
yeah, yeah.
like for us,
It is from the quality side only.
yeah, for us, especially for us, it's not possible to come and get the certificate. So I think you should help us from your level to get the certificate. I mean NOC.
Certificate as in why? Like, is it more than 75 kilometers or how? Why?
I like that we have applied,
Uh-huh.
and then till now we did not get the certificate from the
Is
MPCB.
the facility within 75-kilometer range?
No, we don't have that.
No, no. What I'm saying is the facility within 75-kilometer radius?
We don't have the facility for that. We just have a deep barrier pit.
No, 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 no. What I'm saying is that particular PH in your district,
Mm-hmm.
the PHC or the PHC or the CHC, whoever has applied,
Mm-hmm.
is that hospital 75 kilometers in the radius of 75 kilometer with Sija, or what, like what is the kilometer range?
We don't have that. Like we have in-house. We have in-house.
No,
We
no, no.
don't.
What I'm saying, don't forget about the biomedical waste bit. I'm just asking how far is that hospital from Imphal?
Oh, you mean from Imphal?
Ha, ha, ha.
It will be too far.
No, like, so that's what I'm saying. If it is more than 75 kilometers,
Yes.
we will be providing funds and other necessary resources to get
Deep well.
the burial pit done.
Yes.
Otherwise, if it is less than 75 kilometers and if it is in the 75-kilometer radius than
Ah.
Imphal, then we will be paying Caesar. We will be paying Caesar to get that disposed from this thing,
Okay.
from your facility. So we just need to first identify that facility, whether that facility is within the 75-kilometer radius from Imphal, or is it
Ah.
farther than 75 kilometers from
It
Imphal.
is farther. Much farther.
If it is much farther, then we will when we apply for funds for this thing, CIJA, we have
Mm-hmm.
also applied for funds for the burial pit and sharp waste pit for those facilities who are
Yes.
farther than 75 kilometers. So that
Yes.
will
Yes.
be handled.
Yes. Please. Okay. Thank you.
Loan, it's like we have included some amount for construction of deep burial pit, particularly for the PAC in the hill districts outside 75-kilometer. Within this procedure cannot collect. No,
Yes, sir.
particularly for the PAC only.
What
We have
about
put it.
CHC, sir?
CAC and district hospital, comparatively, they are more, some resources are there. So we have not put, because it's a step by step this thing, because of that, we have not included CAC as of now. We have included PAC first, like just to step by step, no? Like to so that the sub center, respective sub center can give it to the PAC so that it can be disposed in the PAC also. Like that, that's the plan actually.
Okay, sir. I understand.
But right now for CAC, we have not included because at the level of CAC and district hospital, some resources are there also. So we have not included.
Yes,
But
sir.
eventually, if this approval comes in, then we can add it up
Yes, yes.
eventually in the next year
Yeah,
also.
yeah.
Okay. Yes, sir. We'll keep in mind.
Yeah.
Mhm. Okay. Thank you, sir.
Line now. Line now. Line now. Bluetooth mode.